Hey, good afternoon, everybody. I hope you're all well. I'm Matthew Cripps. I'm Director of Behaviour Change at NHS England and Improvement, and welcome to this webinar on delivering net zero targets through environmentally conscious wound care. Thank you to GovConnect for putting this on for us, and also Coloplast, who are sponsoring this. So just very briefly, I'll just give a bit of an introduction, and then we're going to run a poll, and then we'll get into the presentations and ensure that there's time for Q&A at the end. So as you all know, the NHS is committed to tackling climate change by reducing emissions to net zero by the year 2040, with an interim ambition of reduction by 80% by 2032, so not too far away from today. Within this, the wound care plays a major part in our carbon footprint and our ability to reduce it. And in 5 years, in the last decade, we saw an increase in the prevalence of wounds by 71%. So it's on the rise in terms of prevalence, and obviously, as you all know far better than me, the amount of equipment and products and so on, and the carbon footprint of supporting people out in the community, and all of that has a major impact on our current non-delivery of net zero. So we're going to look today at some of the, so I'm going to talk first about some of the behaviour change concepts and things that need to be considered in how we get this level of change to occur across the system. And I'm going to use some live wound care projects that we're working on at the moment to demonstrate the impact that looking at things through a behavioural lens can have over and above a traditional approach to a change programme, especially a transformational one like this. We're then going to hear from Sian Fumarola, who's head of clinical procurement in the West Midlands, and she's going to talk to us about the greener NHS agenda. And then we're going to hear from Paddy Markey, who's a marketing manager for wound care in Coloplast, and he's going to describe 2 practical wound care initiatives to help us reduce our carbon footprint. And then we'll have a Q&A afterwards. So on that, if you would put questions in the chat box as we go, then we'll make sure to pick from those at the end. And before we start, we're just going to take a 1 minute pause while we put a poll up for you to answer. The first, we're going to have 2 polls, one now and one at the end. This first one is just asking whether you're involved in any sustainability projects at the moment. So that poll should go up shortly, and I shall stop talking for a minute or so whilst you answer it, if you would. Thank you. You have to, if you click on polls, I think you need to click on polls to get the answer, to get to it.
The poll's live up for the registrants. Thank you all. Thank you for answering our poll today. Thank you, Matthew.
Okay, thank you very much. Right, so on to the first of the presentations, which is me, and I'm going to talk to you about behaviour change and how we can apply behavioural concepts and the behaviour change approach to this level of change. So I run the behaviour change team in NHSEI. Our name is forever changing for some reason, so we've been behaviour change team since April last year, but for a year or so before that, for 15 months, we were the behaviour change unit in the COVID task force, helping with some of the changes, often very significant changes that were needed, not just across the population, but also across the clinical frontline and the people within the system between NHSEI nationally and the frontline. Prior to that, we were also working in behaviour change, but in the medical directorate of NHSEI. So we've become involved in the last 6 to 8 months with the AHSN and NHSEI wound care strategy, in particular to help look at digitisation of photography within wound care. The National Strategy Programme has the aim of improving the prevention and care of pressure ulcers, lower limb wounds and surgical wounds, and is looking to improve patient care, reduce patient suffering, reduce unwarranted variation, improve the healing rates and reduce recurrence, and make the best of our finite resources. So to support the digitisation component, my team have been working in partnership with wound care leads on the front line, AHSNs and national wound care leads as well, to try to gain insights from the front line and the managers of the people on the front line, the team leaders, etc., what the key barriers and drivers are to adopting these types of behaviours, and to try and understand what we could do to help people adopt these more sustainable behaviours over time. And we're doing that by initially doing a deep dive into what are all those factors, what do the front line actually find gets in the way of them being able to make these behaviour changes, and what would the system look like if those barriers weren't there. And then how do we persuade and enable the system towards these changes once we know what the system should look like. So, but before I go into that, I thought we'd step back a bit and just talk a little bit about what behaviour change and behavioural science is. So according to the London School of Economics, behavioural science brings together a lot of different academic areas and puts them together to try and understand what's going on in terms of human factors that sometimes drive us to make changes and sometimes hold us back from making changes, even if they're evidence-based. So it brings together all sorts of specialisms like behavioural economics, cognitive psychology, marketing, health and healthcare, biology, neuroscience, even philosophy and well-being, and so on. Behavioural science is all about understanding choice making. So how do we consume information to aid our choice or decision making? What do we do with that information? Which of those things that our minds, what our minds do are good, and which of them are not so good? And how, when we build a national programme to cascade down to the front line, can we account for all of that to make it help people on the front line see that the evidence supports this change, see what the change is that they're being asked to do, and then once they've chosen to make the change, to do so as accurately as possible to get the best benefit for the population. One of the models that most behaviourists use most commonly is called COM-B, and this captures the three key categories of what goes on in a project and what goes on in a human to lead to whatever the behaviour is that they end up enacting. So the COM bit of COM-B is capability, opportunity and motivation. So capability is whether we have the psychological and physical ability to actually do something. So in terms of psychological capacity, what we mean is, are we aware of the issue? Are we aware of the need to change? Do we understand the case for the change, and do we know enough to be able to do it? And the physical ability is, have we acquired the skills to make the changes? Opportunity is about enablement, and have we been given the opportunity to make the change that we are hopefully capable of making? And a really common one within healthcare is access. So an individual may be capable of going to get their vaccination for COVID. They may be motivated to, but if the vaccine centre is on the other side of town and takes 3 buses, and you don't have a car, access to a car, and you don't have the time to get all those buses, or the cost of living crisis, the money to go and get them, then you may be capable and you may be motivated, but we, in the way we've designed the system, haven't provided you with the opportunity to make that behaviour change. And then the third one is motivation. So you may be capable, we may have provided the opportunity, but are you motivated? Are you compelled to do it? Are you convinced by the case to make that behaviour change, and so on? And if you are able to build something that captures all of those three, then you're far more likely to deliver the behaviour change, or help people to choose to deliver their behaviour change, than if you don't capture all of those three. In order to capture all those three, you have to understand them, and so that requires various investigations analysis and interviewing the people who actually want to make the change and so on. And there's a fairly generic 3-phase process to behaviour change programs and projects. And they are behavioural mapping, behavioural de-risking, and behavioural framing. So behavioural mapping is right at the beginning of a piece of work, understanding what are the behaviour changes that we're actually trying to deliver, and who are the people that we want to make those behaviour changes. So at the end of behavioural mapping, you have, these are the things we want to change, and these are the target audiences, the population cohorts that we need to work with, because they're the ones who need to ultimately make that change. And once you understand that, you can go into behavioural de-risking, which is to actually go to those people and explore with them, what are your motivators, what are your enablers, can we enhance those enablers and those motivators, what are the barriers, what will get in the way of you choosing to make the change, or even if you wanted to make the change, what are the barriers to you being able to make it, and so on. And how do we design in all of those positives and design out all of those negatives to try and give the best chance for the people that we're trying to support to change to be able to and to want to. And then once you know that, you move into the 3rd phase, which is behavioural framing, which is, okay, we now know all the things that need to happen. We know that we have to tweak the system. We know we have to inject extra capacity or resources or equipment or whatever into that and so on. But how, when we convey this to the front line, do we frame everything in a way that makes that really clear, really compelling, and really supports people once they've chosen to change to enact the change? And so there are various parts of that. I'm going to now go through some examples of how this comes to life, and I'll go into the wound care work that we're actually doing at the moment as part of that. So on motivation, one of the key things when you're trying to enact change on the front line in the health system is you need to get the cascade through national to regional to local system to frontline right, so that all of those individual actors, as they're called in behavioural science, to act out the behaviour that you need them to enable the next part of the system to be given the opportunity to enact out their behaviour and so on. And one of the ways of doing that is known as tick all of the boxes, which is that if people are compelled by the need to achieve sustainability and to hit that net zero target, people who are motivated by that, perhaps all they need to hear about is that this is going to help you with net zero, and that'll be enough for them. But that's not enough for every single person. Each individual is motivated by different things. So if you just focus on the sustainability aspect, you'll win over some people, but you won't win over them all. Equally, if you just focus on wound care innovation, so changing wound care for the better, that will motivate many people working in wound care. But again, it won't necessarily motivate them all. It may not motivate the manager, the general manager who supports those teams. It may not motivate the system leader for whom wound care is just one of 40 things that they have to try and oversee and so on. It may, and so on. Equally, even if you were to demonstrate and create a compelling case for make this change because it will benefit the wound care agenda for the population and the workforce, make this change because it will also help achieve the net zero target, some people may not be compelled and motivated by those two together. For example, finance managers, no matter how much they care about the population and the sustainability agenda, they won't get paid and they won't be able to pay their mortgages and feed their families if they don't tick the finance box. So they may want to be motivated by the first two, but they can only be motivated if you also tick their box of this has to achieve an efficiency, it has to deliver a saving. It's your job to make sure it does. So tick all the boxes is to find that central ground in that Venn diagram of what is the case, what case can we make that delivers all of the things that all of the key people in the system need to see are delivered in order to be compelled by the case to change. And exploring that from a behavioural concept early on helps you to build that case to make sure you capture all of the key players and their motivators. An example of that from COVID, you may recognise that poster from one of the first COVID posters. It's one of the first things we did in the task force was to come up with that four-word nudge, protect yourself and others, and protect became the theme of the COVID work on trying to help everyone to change their behaviour and spread across the world, as I'm sure you probably recognise. It was on lots of the lecterns of the politicians and so on. The reason that we came up with Protect Yourself and Others is because it ticks two boxes in terms of motivation. First of all, it ticks our innate desire to do the right thing for the greater good and for our community. But also it ticks the box of our innate desire to look after ourselves and our survival, and it triggers our survival instinct. So Protect Yourself and Others essentially created in people the sense of, right, hang on a minute, so I can pat myself on the back by being selfish and protecting myself, because by protecting myself, I'm also protecting others. So that was the thinking behind it, and just an example of two motivators together in one case, one to change. Other things that we do is try to explore with the front line. We always try and go to the front line as early as possible, and preferably right away in all of our work, because it's the front line where most of the changes that we're trying to enact need to occur. So it's the people on the front line who have the key barriers and drivers that need to be dealt with to enable them to then do the changes that the evidence supports. So this is an example of the results of a survey we did when we did a piece of work on nosocomial transmission in the system. I'm not going to go through it in detail. It demonstrated what we probably already knew, which was where the most transmission was happening in hospitals and other healthcare settings during the pandemic. But the reason I'm showing it is because we then went underneath these bar charts to find out what are the things that are happening in your team rooms and your changing rooms and your shared workplaces and so on. And what we discovered was stuff that we would never have found out if we hadn't talked to the front line. So one example was that in break rooms, one of the main sources of causes of transmission was handling each other's mugs of tea. And the reason we were handling each other's mugs of tea was that although we knew it was wrong in the context of transmitting COVID, it was such a cultural barrier to get through, to not make your friend a cup of tea while you were making yourself one, that people were knowingly breaking the rules because they couldn't bring themselves to make that cultural taboo of not making the person next to you a cup of tea. So what we then started to do was to start building some posters and some messages out there to basically make it a temporary virtue to not make each other a cup of tea, not hug each other when you meet up after you haven't had a shift together for a while, and all these types of things. In order to understand all of that, we had to speak to the front line. I'm now going to hop across to the wound care digitisation programme and some early results. It's still very much work in progress. But this is a word cloud of the things that are coming out from our initial conversations with the front line. So we're doing two things. One, we're having a series of in-depth interviews with members of the people from the front line to understand what are the things that are happening out there for them on a day-to-day basis. And the other thing we've done is we've given a number of frontline wound care workers dictaphones to audio record their day in detail, so like an ongoing diary of their day, so we can start to understand what are the barriers you're constantly facing, what's getting in the way, what's actually helping that we can enhance, and so on. And this word cloud demonstrates the key themes that are coming out from all of that work. So management general, working expectations, and so on. All really valuable insight to a national programme that's trying to build something that helps the front line. One of the reasons I'm showing it is this. Again, I'm not going to go through this in detail, but this is the table that our behaviourists are putting together as they build up this insight and talk to more and more people and work through more and more of those audio diaries. And what it's highlighting is two things. First of all, the main themes of the barriers and the drivers, so those top 5 from all sources, but also something that really demonstrates the importance of doing things like this from a behavioural lens. So, for example, sorry, that's my reminder that I'm running out of time, so I shall whiz through now. But just very briefly, that you see in the middle column, those top 5. So that's what the managers of wound care teams think are the main barriers for the front line that they manage. But then if you go across to that third column, the front line themselves, it's not actually the same thing. When you ask the frontline clinicians, what are your main barriers? you get a different list. So if you don't, if managers don't try to help their teams via that behavioural lens, then they will do things which they think are helping the clinicians, but they're not actually the most important things that they could do. And then if you go back to nationally, if we only talk to the managers, we'll come away with that middle column as the top 5 key areas, but it's not actually 100% accurate. It's the clinicians' top 5 that really matter and we really need to focus on. I'll just whiz through the rest of these, but that's an example of one of those temporary virtue things that we did with nosocomial. So basically making it a virtue of not hugging your friend for a while. Here's some infographics which create environmental prompts. So if you put these up, it helps people do the same consistent process each time that is the behaviour change that delivers the better outcome and so on. This is an example of how you can change prose narratives into process maps and checklists to move not just from conveying information and knowledge, but also how to practically apply that information and knowledge within the same page of a document. And this goes back to that point I was making about talking to system leaders and managers and so on. This was a do's and don'ts crib sheet for system leaders and managers to help get the vaccination programme rolled out. So do this when you talk to your teams and with your organisations. Don't do these things. The do's will enhance impact and the don'ts will avoid damaging impacts by not doing them and so on. So you get all of that insight from this approach is particularly talking to the front line, and you can then work back and work out what each part of the system needs to do to enable the next part of the system until you reach the front line and get them as most enabled. I won't go through this slide, but I'm sure we'll be sharing the slides. This is a journal article that we recently had published about digital innovation and how to achieve behaviour change in digital innovation, just as in any innovation, the focus should not be so much on the innovation itself, but should be on the context within which the innovation is going to be used, i.e. the people out there who you're trying to get to change and use it. Speak to them about what will enable them to use it. Don't just try and show off the innovation, because that doesn't compel everybody, a bit like that tick all the boxes that I was describing. So I'm sorry for going slightly over. So I shall now hand over to Sian, who's going to talk to us about the greener NHS.
Oh, thank you, Matthew. That was really, really interesting presentation, and certainly going to give us some, well, certainly give me some pointers anyway about how to land some of the projects that I've been tasked with. So I am a head of clinical procurement, and I work across 5 organisations, quite big acute organisations in the West Midlands area. And you know, you might think, well, what does that mean? So what I do in my everyday job is I do have a team, so I don't do this all by myself, but we're responsible for reviewing, evaluating the utilisation of clinical products that come into our organisations, either as new products, innovations, or maybe just a swap, you know, for a cost saving maybe. But it's just to make sure that, you know, we've got some governance there around quality, safety, value. You know, we've always got an eye to value, but it isn't the main driver. And also around sustainability. When I came into this post and I realised that sustainability was in my portfolio, to be honest, I wasn't really sure how that was going to impact my day-to-day delivery of my role. But I can tell you, it's almost completely taken over my life. And for very, very, very good reason. So for every product line that we look at now, we do look at sustainable losses or sustainable gains. And we can use this sometimes as a lever for our clinical colleagues to implement quality improvement processes with them, where there's a clear sustainable gain, and we can help them to map that out. So, you know, you might be thinking, well, you know, what's all this about? So technically, you know, the carbon footprint it's the sum of the direct or indirect greenhouse gas emissions, which are attributable to any given processes, which is what we were talking about, product or organisation, because all of our organisations have their own carbon footprint. It usually includes the 7 greenhouse gases that were covered in the Kyoto Protocol, and I've listed them above for you there. I'm more than happy to share these slides with you. And as greenhouse gases have different global warming potentials, the carbon footprint is expressed as carbon dioxide equivalent. So I know that sounds a bit technical, but that's, for me, that's how I kind of simplified it for myself, really, to understand what it was all about. And of course, you know, we have all been tasked with delivering this net zero project for the National Health Service, and it's really important. It's not just important to us as organisations, but as I've realised, it's important to us all as individuals as well. And all the clinicians that I talk to all have a view about sustainability, and they can all offer, you know, projects or improvement processes or so on that are really sort of focused on sustainability. So we've got two clear targets here for the NHS net zero commitment. The first one is for emissions we control directly, and that's called the NHS carbon footprint, and we're tasked with delivering that by 2040. And the second is for emissions that we can influence, and this is called the NHS Carbon Footprint Plus, and we're tasked with delivering this by 2045. Now, I could spend a lot of time going into this in some detail for you, but we just don't have time today. But you can, you know, you can Google this, and you can look at the documents, and they'll explain to you in detail what that means around, you know, transport, fuel, products and so on, and it'll give you a wider understanding of how we can all play a part. And of course, we can all play a part. You know, we have a climate emergency. I don't think there's any, you know, there's no conversation to be had about that. We definitely have a climate emergency going on, and a climate emergency does mean a health emergency as well. And we'll have all seen this, those of us who've been working in the NHS for some years, you know, that that general impact on health, and not just us in the UK, but globally. And, you know, there's lots of evidence of this. The NHS is the largest employer in the UK, and we produce 4% of the nation's carbon emissions. So that's absolutely massive. So you can see now why we really need to focus. The NHS is the largest publicly funded system in the world. We've got more than 200 trusts, 7,000 general practices. We prescribe more than 1.1 billion items, and that's drugs and also medical devices. Reaching ambitions set out by the Paris Climate Change Agreement, we will save over 5,700 lives annually if we improve air quality. And all of the things that we do contribute to air quality, you know, and also that improvement in healthy diets and exercise, etc. The greatest opportunities for these improvements are through supply chain, estates, facilities, pharmaceuticals, medical devices and travel. And many of these things impact what we do in wound care, because I know that's our focus here today. The World Health Organization estimates that over 80% of the illness and injuries and deaths due to climate change are in children. That's absolutely astonishing, isn't it? You know, and that really makes us think very, very hard about this. The climate health emergency means that the Great Ormond Street Hospital wanted to become the first net zero carbon organisation by 2040, and they've done an awful lot towards this. There's lots of other organisations that have kind of joined these projects now, but they were really the first ones to set up a young person's sustainable forum, climate emergency responders and green champions, and many of you will have green champions working in your clinical areas and in teams that you know that you work with, and you may well be one yourself, and if you're not, you might really want to think about it after our presentations today. So just thinking about the NHS then, you know, the activity that goes on in the NHS. A recent Department of Health policy paper indicates that there is some significant impacts on future delivery of our services. The NHS activity is growing by 3.3% annually. In the past 9 years, A&E attenders have increased by 4.3 million. And we're all aware of this, aren't we? We're all aware of all the emergency situations and, you know, the capacity flow issues that we've had in our acute organisations as a direct result of this. 17 million inpatient admissions, outpatient attendances have increased by 36 million. And I know we've had a bit of a blip in this during the pandemic, but this is escalating rapidly again. 270 million primary care appointments, 1.9 million requests for adult and social care support in 2019-20, and of course that will be increasing now as we know. In the next 20 years the population will grow by 10%, so all these things will impact on our services and products that we use, and then of course they'll all impact on waste streams as well. Population over 75 years of age will grow by over 60%, and that section of the population target NHS services more than the younger population. So you can see again how this is all impacting, and around 20% of our lives is spent in poor health. And of course, during COVID-19, we're beginning to see, that short, medium and long-term effects on healthcare. And this is how this is going to escalate. We've seen that deficit in many of our services. And so we've seen increasingly poor health in a percentage of our population. So, what's the NHS doing about this? Well, this is, you may not be aware of this, but the NHS standard contract in 2021-22 really did look at sustainability and what that means for us. So just a few points from that document. So point 18.2, the provider must maintain and deliver a green plan approved by its governing body. You will all have a green plan now because they had to be in place by the beginning of April this year. That we must provide an annual summary of progress on the delivery of the plan, and many of you will have been asked to submit data around this, and the people will be very interested in project work that you're undertaking now. And also we must nominate a net zero lead and ensure that that they are coordinating their activities with commissioners. You will all have a sustainability lead. I have sustainability leads in all my organisations, and I do work very closely with them now. So percentage of emissions, so the NHS produces works with more than 80,000 providers. They provide medical equipment, foods, business, office services. More than 60% of the NHS carbon footprint is based within that supply chain, and this applies to all of us because we're all ordering, purchasing, using this equipment. Support from the suppliers is crucial in achieving that net zero, and I know suppliers are working very hard with us. And to support that, we do have a net zero supplier roadmap. I won't run through this in much detail with you, but it is available in the public domain if you want to read this. But it's saying that really we want suppliers to work with us as from our national procurement teams and our local procurement teams as well. We want them to be looking at, have they got a green plan? What does that mean to them? How are they delivering? And not just from a corporate point of view, but how are they actually landing that? Are they changing their packaging? Are they looking at electric transport for delivery and so on? Are they looking at the life cycle of their products? So it's going back to the plastic pledge. Are you aligned to the plastic pledge? So the plastic production is a carbon intense process, and plastic waste has a significant environmental impact. I don't need to tell you that, do you? You'll have all seen, you'll have all seen that, the programs around this, and you'll have all seen those images of the seas of plastic and so on, and we are actively contributing to that. NHS supply chain data from way back in 2015 said that catering products accounted for more than 5,600 tonnes of plastic that they procure, and we're doing a lot really to address that now. And in 2018, the NHS purchased 163 million plastic cups. All that plastic, pieces of plastic cutlery, stirrers, straws and so on, takes about 300 years to biodegrade, if it biodegrades at all, and then it's going to biodegrade into very small pieces of plastic that just get into our water streams. So every piece of plastic that you use, and we've seen this escalating during the pandemic as well. One of my trusts was actually aligned to the plastic pledge very strongly, but we've seen a lot of single-use plastic creeping back into the system, and that does much of that does go to landfill, and it stays there for many years. So you need to think very, very hard about bringing in a ceramic mug into work now instead of using those plastic disposable items. We are increasingly unable to purchase those things now, so we are having to move away from them. But if your trust isn't aligned to the plastic pledge, then I would strongly advise you to talk to your senior teams about that now. Healthcare waste. So, you know, you think about the amount of waste that your organisation produces, and the World Health Organization tell us that high income countries generate 0.5 kilograms of waste per bed day, and that's much higher in low income countries. 85% of that is non-hazardous, and 15% is considered hazardous material, infected, toxic or radioactive. You know, we all have to think about where is that waste going to. We spend lots and lots of money every year on waste management, and of course that's escalated through the pandemic. In 2020, the majority of our global population, which is about 7.8 billion people, sought out PPE. You know, it was an absolute essential, was it? So think about all the masks, the latex gloves, the protective aprons, the hazmat suits, all of that we had to wear during that time, and we're still wearing in many situations now. Nearly all PPE is non-recyclable plastic. At the peak of the pandemic, a hospital in Wuhan, which was initially the epicenter of the pandemic, produced more than 240 tons of single-use plastic medical waste per day. That is really scary, isn't it? And I can say that some of our big institutions were probably very close to that as well, which was 6 times more than their daily average pre-pandemic production. And we can see this, we can cost this out now in our organisations, you know, the cost of our waste management over the last 2 years. You know, UK trusts use 10 million items of PPE every day, you know, and that all went to incineration, some of it went to landfill. I just touch on this briefly. There is, you know, obviously there's a big focus on medicines and medical gases, but I touch on nitrous oxide because as wound care practitioners, many of us do use Entonox gas or nitrous oxide as part of our, as a necessary analgesia in some of our procedures. But you know, there's a real focus on nitrous oxide. It's got a particularly high carbon footprint, so we do have to be very careful about the way we use it. It's about 300 times more potent per kilogram than carbon dioxide, and it's responsible for 6% of the UK's climate impact. So we're doing a lot of work now on scavenging some of these chemicals from the air as we're using them, and diverting away from canisters and to piped sources of nitrous oxide in clinical areas. So just something else to think about. You know, I mean, if we need nitrous oxide, we need it. I know that, but we just need to have a think about the way that we manage some of the cylinders that we use. I'm just putting this into some kind of context, really. I know you'll probably all be familiar with the work of Guest and his colleagues, you know, and when they reviewed some of their data around the spend and numbers of wounds, they found that, you know, in the 5 years between their two pieces of research, they found that there was a 48% increase in wounds. So if we start to equate that to some of the things that we've talked about already in terms of product, services, transport, outpatients, appointments, all of those things that we looked at in one of the first slides, you know, the NHS activity, you can see that all these people with wounds are actually in contact with NHS providers, you know, on a very regular basis. And of course, if we can't support healing in those wounds, then, you know, then this can continue for quite a number of years. So, you know, it's something for us all to look at, and a really interesting project of one of the North East of England trusts. They looked at the use of gelling fibre dressings, and they were using over 22,000 sorry, let me say that again. One trust in the North East of England reduced the use of their gelling fibre dressings by over 22,000 over a 12-month period. And that 22,000 dressings not used equated to 251 tonnes of saved materials. Now, you might think, oh, well, that's kind of a small step, but actually, if we were all to do that, can you imagine what that would mean to the NHS? And if you think about where these dressings go, I know in acute organisations, this is clinical waste, and many of those products, well, all of those products will go to an incinerator, but in the community, some of those products, in fact, many of those products go to landfill, don't they? So, you know, we need to think about polluting the environment as well as the carbon footprint there. So you can see there, you know, the number of tonnes of carbon emissions that were saved in that one reasonably small project. So that's something for us all to think about. but also kind of moving on from that, looking at the way that we procure products, the way that we monitor products. We know we've all seen evidence of this, haven't we? You know, that stockpile of product in patients' houses and the waste there. You know, so actually, if we monitor that more effectively, the outcomes can be so much better. So, and this is actually a piece of work that happened in one of my organisations and has progressed quite a lot since then. I don't know if Paddy's going to talk about this after, but this is looking at an online non-prescription ordering service for wound care products. It's a way to procure products more smartly, not just products but services as well. It supplies real-time data reports for usage and spend, and you know, and I can tap into these regularly. We can see, you know, who's using what and whether we are compliant. And if there's a sudden increase in a product line, we can ask those questions. Why? Could we be using something more effectively? And it has had a significant impact on reduction of waste, particularly in those community areas. And of course, as we said, improved product awareness for clinicians and time management as well. And it also improves the patient experience. We're also beginning to see evidence of this in acute organisations, and Chesterfield Hospital addressed some of their unwarranted variation by reducing the brand range from 41 to 14 products. And we're also able to demonstrate, a reduction in waste product as a result of that. And I know that's something that some other acute organisations are also looking at. We have to think that over 1.4% of supply chain emissions are due to single-use devices, some of which could be refurbished and reused, saving the NHS both carbon and money. And I'll just leave you with that thought, because I know lots of people are kind of thinking about the way that they use some of these disposable devices and how we could improve that. And you have to remember that we are the customers here. So, you know, we really need to be talking to our suppliers about this. So just to sort of, just a few thoughts to leave you with, so some things that you know might impact your future delivery of your services. So approximately 1.3% of all road travel in England relates to patients, visitors and staff. So if we can improve that at all, that can be quite significant. The duration of the wound, so, you know, taking into account best practice guidance, nice product evidence reviews and clinical product specifications, you know, so that we can be a bit more savvy with the way that we use products. Self-care options, lots of debate around, you know, how we support patients to self-care, so that we might cut down on some of those hospital visits or some of those nurse visits to the patient to empower them, patient contact requirements as well, and implementation of new product lines, logistics and cost and educational resource available to support those new products so that we use them appropriately, and also looking at, you know, their plastic content as well, things like that. So I think I've got two people up on the screen with me now, so I assume that my time is up, but I just hope that that gives you a little bit of food for thought. Thank you.
Thank you so much, Sian. Fascinating, and as someone's put in the chat, some mind-boggling challenges and stats there that we can all look to try and do something on. So I'm going to quickly move on to Paddy, who's going to give us talk us through a couple of practical initiatives within wound care to help with this agenda. So over to you, Paddy.
Thank you very much, Matthew. Many of you have seen these numbers before, and Sian just referenced them in the Burden of Wound study. I guess what it says to me is that there's a recognition by all involved in wound care that the service and the delivery of wound care is under significant stress and strain at the moment. And the reasons for that are fairly variable. You've got a change of demographics, both of the patient and of the healthcare practitioner, in that patients are living longer with more complex comorbidities, and the profile of the clinicians who are doing wound care is changing dramatically. And the next slide will actually show that. But in conversations with clinicians across the country, everybody highlights the need to manage an ever-increasing workload with an ever-diminishing workforce. So the resources and personnel involved in wound care are not aligned to the increasing caseload, which Sian had mentioned earlier. And Guest estimates that is going to be in the region of 10 to 11% annually. So there's a need to simplify wound care. And part of that reason is also looking at who conducts the wound care. This again is from the Guest work, the health economic work, which was definitely a landmark study in this area. But you look at just two of the large peaks on this graph, it shows that on the left-hand side column is the data from the first burden of wound study, which was data collected in 2012 and 2013. And on the right-hand side is the data collected 5 years later. And you'll see the massive shift and change in demographics of who is doing the wound care today. So there's a huge increase in district and community nursing, but also a huge increase in HCAs conducting wound care. So that highlights the need for simplification. And how do you deliver a sustainable wound care service while also improving outcomes, increasing efficiencies, reducing spend, and being environmentally conscious? So we wanted to share with you a few local initiatives that have taken place in some trusts across the UK, just to give you some ideas on how some of those targets can be met. The first one, which was mentioned earlier, was the Gap Challenge. Now, the conclusion is that if you look at the assumption that 80% of all wounds are no more than 2 centimeters deep, and current standard practice is for those wounds to be treated with a filler and a secondary dressing. And in an evaluation that we conducted, which was published both at Wounds UK in 2019, and then subsequent work that was published at Wound Care Today, we looked at, this data shows the results of 137 patients, looked at both in England, Scotland, and in Ireland. And what's interesting when you see the numbers is that 60%, so 84 of the 137 patients were using 2 or more dressings. There were instances of more, 3, and in some cases 4 dressings being used on some patients' wounds. It's also interesting to note that when this evaluation was looking at Biatain Silicone, it showed that 90% of the HCPs reported that conformability to the wound bed was perceived as excellent and very good. And the next slide will just post-lunch just demonstrate, we always have to stick in a picture of a wound, but this is a picture of Biatain Silicone after it's been removed from the dressing, just to demonstrate what we're talking about when we talk about conformability to the wound bed. So you'll see it is very symmetrical to the edges of the wound and the topography of the wound bed. So that's one number I wanted you to remember that John had mentioned, was that 22,000 dressings were saved across the northeast of England when they adopted Biatain Silicone. So we'll just capture that, I'll come back to that a bit later. The next sort of incentive or initiative is around ONPOS, which is the online non-prescription ordering system. So that paper was published again in the Journal of Community Nursing in 2020, which looked at what are the benefits of ONPOS, a non-prescription ordering service. And it's well recorded and well published as to what the benefits are in terms of improving formulary compliance, reducing overall dressing spend, reducing wastage, which was talked about earlier, but also in this case was looking at the reduction again in SKUs. So that is a stock keeping unit. So the numbers of individual dressings that were reduced during the period of introduction of the ONPOS system, as well as Biatain Silicone and 3D Fit technology on the formulary, as well as the introduction of pathways. So it's interesting to see that data, which hasn't been published before, about the impact on reducing SKUs and the number of brands being used. So the number, again, I want you to remember for the next slide is 36,000 dressings. So over a 1 year period, the Gap Challenge in the northeast of England reduced the number of jelly and fibre dressings by 22,000. And the non-prescription ONPOS system in Wolverhampton reduced the number of SKUs by 36,000. So what does all that mean? It means that some of the things that can be done right away. So Coloplast is obviously a supplier and manufacturer of products. And as John mentioned earlier on, a life cycle assessment. And that are some of the models that exist from suppliers and manufacturers that look at all elements of the pipeline, all elements of the supply chain, going right back to the original sources of raw materials. And you can track all of the raw materials, resources, and energy required to manufacture your products. And those are usually communicated through life cycle assessment modeling. So we have taken the 2 examples I mentioned earlier and populated those into the life cycle assessment tool to show what are the impact in reducing raw materials, in packaging, waste, plastics, and also CO2 emissions. So on the right-hand side, you will see the mention again of 22,200 individual dressings. So that's what was saved over a 12-month period by initiating the Gap Challenge. Now, again, as manufacturers of a wide portfolio of products, we have the raw material information for our product, Biatain Fibre, 10 by 10 dressing. So that's the assumption and the caveat we have made in this analysis. But once that data is inputted into the model, you'll see what type of outputs it generates. So you can calculate the amount of saved plastic. You can calculate the amount of saved materials, including all the other packaging materials that go in to providing a sterile product. You could also calculate the CO2 reductions and emissions related to the product manufacture itself, but also significantly the product transportation and distribution. So collectively, you have a saved sort of CO2 number of just over 1,100 tons of CO2. And collectively, this raw material and packaging material saved is just over 300 tons of materials per year. We did a similar exercise on the left-hand side, which looks at the results of the ONPOS data. So taking that number of 35,908 dressings that were saved, we made an assumption based on the data we have for Biatain Silicone 10 by 10. And when you input that data into the model, again, you get similar outputs in terms of saved plastic, materials that are involved in the packaging process, and the CO2 saved from the product manufacture, as well as transport and distribution. So it's a larger number, but you'll see again, collectively, you're saving just under 1,000 tons of raw materials per year, and you were saving nearly 3,000 tons of CO2. Now, you probably think there's lots of numbers that have been shared during this session, but actually, if you combine those two, what is the impact of reducing 4,000 tons of CO2? And the best analogy I would say is it's roughly the equivalent of taking about 870 passenger, typical family cars off the road for a year. So these are just two initiatives that can be started. And again, they're just examples from two individual trusts. But collectively and cumulatively, if these projects and initiatives were to be rolled out across 200 trusts that were mentioned earlier on, it would have a significant impact in delivering a sustainable wound care service, but also in delivering environmentally conscious wound care. Thank you.
Thank you very much, Paddy. So we're now going to move on to Q&A, although first of all, I thought I would just quickly, in case you haven't looked yourselves,
I think we have lost Matthew for a second.
I think I've lost my camera as well, Paddy. Don't know if you can see me. I can't see me.
We can see you, Sian.
Oh, okay. It's not on my screen.
Would you two like to please open up
Yes.
the Q&A whilst who's coming back on? Thanks.
I wanted to ask just a question to Sian about when she mentioned the Great Ormond Street declaring a climate emergency. Are they the only trust in the country who have done so to date?
No, they were the first trust to do so, but there are many, many, many trusts that are doing the same thing now. And also in the background, now that we all have leads for sustainability, which is, as you saw, it's a requirement of the NHS contract now. So because we all have these lead people, they have networks of green champions in all areas now, and I'm sure everybody now knows a green champion because it is a requirement. And what they do is they feed into the sustainable leads with any, we might think of small projects that can help with the sustainability goals. And one of those very small projects, well, we've had lots of them, but one of the things was just realising that we were using in one of our theatre suites, the staff were using those little pods of milk, you know, the little 5 ml packs of milk instead of using, you know, a proper carton or bottle of milk. So we were able to address that, but it just gives it just gives that avenue really for clinicians, you know, working on the front line to feed this into people who can make this happen very, very quickly. We're doing other things as well. So we took out all the plastic straws. We are looking at things like reusable tourniquets now instead of the single use. We use millions of single-use tourniquets in the NHS, and we're starting to look at the reusable ones, because some of our pathology services, you know, they'll bleed over 1,000 patients a day, so that's 1,000 saved tourniquets. So it's all those kind of things that people kind of bring to us now and say, how do we make this happen?
Hopefully you can see and hear me again now. Sorry about that, I got booted out. Hopefully I'm back, but Paddy, I'm afraid I can't see the chat or the Q&A. It's not come back up when I've been let in, so I wondered, would you mind taking over the chair for me?
Yes, a few questions have come up. So Phil Stimpson has asked a question from the AHSNS, playing an important role in working, education, training suppliers of innovations, and more can be done. And he's asked for our thoughts on, I guess, gathering evidence to support some of the concepts that we've talked about earlier.
So, from my perspective, I'd say absolutely, and they are active, but like all of us, I suppose they can do, be encouraged to do, and given the opportunity to do more. So the work that I described at the beginning on trying to encourage more digitisation via this behavioural approach is actually commissioned by the AHSN and NHSEI, and we always work in partnership, we embed with the teams actually doing the work, and the bulk of the people in it are AHSN people. So they are active, but that's not to say that we couldn't do more, because I think in terms of the green line, I just think we all could, couldn't we?
Thank you. And Shan, what's your opinion on I guess, in terms of evidence gathering, in terms of the role of the AHSNS?
Well, you know, I mean, I've had quite a lot of conversation myself with the Academic Health Science Network about how we can kind of take them off. We've shared a lot of our kind of small project work that we've done, and I know they're supporting us at the minute with something around value based. So we're looking at some urology devices. Excuse me. We're looking at some urology devices that actually give us, and the output from that from a sustainability point of view, because there's always a sustainable gain in these pathways, is that the procedure isn't as long, so we use less product. The patient doesn't have to come back to hospital for multiple visits, and the patient doesn't have to stay in hospital overnight, and we use less equipment. So when we're talking about some of these patient pathways and value base, then we're quite often talking to the Academic Health Science Network about that, and they're supporting us with that. And our kind of messaging out to suppliers all the time, of course, now is that whenever we secure a tender, we have to put a 10% weighting in there now for sustainable value and social value. So the suppliers are now having to work with us, and I must say, you know, that they're more than happy to do this, you know, for us to say, actually, if we take this product on board, you know, and it can be a wide range of products, we take this product on board, what does the patient pathway look like? Which pieces can we take out of the patient pathway, and what will be the gains here? You know, so your product may cost slightly more, but actually, you know, the cost gains and also the sustainable gains will be more ultimately. We're only part way down this path because we don't understand yet the embedded carbon per product, but that's coming. That's coming, yeah. And suppliers are helping us to map this now, so that we can say, actually, the embedded carbon, and I suppose if we're looking at dressings, the embedded carbon in this dressing is this much, and if we add it into the pathway, the embedded carbon in the pathway is this much, as opposed to this alternative product or process or procedure. So that's coming to us very, very soon, but it's not quite here yet. But that's really what our finance. I know we talked a little bit about finance. Matt talked about finance there, and we said, well, how do we give them the gains? They want pound notes on the table, don't they? When we say we want to change a pathway, you know, well, once we understand the embedded carbon, then we will be able to translate that into pound notes for them. Yeah. Because there's a cost to waste, isn't there? There's a cost to bed day time. There's a cost to a visit. So
yeah. Just one question that popped up in the chat, which Sian, you might be able to answer from a clinical procurement perspective, because it's from Heidi, who asks, they moved to reusable linen in theatre, and they went from linen to paper material. But she was questioning, what's your view on the infection control issue, or is there an infection control issue?
Well, the linen will go to a linen service, so there's no infection issue there. There's no cross-contamination issue, and we have two types. So we use drapes and we use gowns, and we're beginning to introduce reusable theatre hats and so on as well. So we're still looking at the embedded carbon there. So we've tried to map this out in some of our organisations, because there is a significant cost increase there to use reusable linen and gowns and things. At the moment, some of those items are coming to us what we call the PPE push. So gowns are still coming to us through the push. So then we're not actually paying for them at the minute. But when we do pay for things, there will be a cost disadvantage to us of using products that we sort of recycle and go to the laundry, and they can either be sterile or unsterile products, so we don't worry about the cross contamination there. And we're just trying to map out actually what the sustainable gains are, because of course when we send a product to a laundry, there's an awful lot of energy requirement there to turn that around. And then of course we're asking questions about, at the end of the life cycle of the product, is it recycled itself? So we're just working with our local laundry services to try and map that out, but we're really not sure whether, at the moment, what the sustainable gains look like there. But we are using some of those products, and to be fair, the staff prefer them. They prefer them to the disposable items, so from a social value gain, it's better.
Yeah.
Sorry guys, just to let everybody know, we will be running over, so as long as you need. Matthew, have you got the Q&A now up on your screen, or has it not come back since you logged back on? Oh, he's on mute as well. You're on mute, Matthew.
I've got some up, but I'm not convinced
Okay.
I've got all of them. So
Paddy, do you want to continue then, as long as everybody's okay to run slightly over?
Sure. There's one question which Wendy had asked about green shipping lanes, and I assume that's in relation to the life cycle assessment model. I don't know the answer to it, but I will certainly find out. We work very closely with our sustainability team and colleagues in Denmark who have access and run the model. So if I can come back to you on that one, I will find out and be able to get you a response. There was a few other questions around, I guess, the sort of interaction between infection control and sustainability. And I think, Sian, you've covered some of those points, but is there any other experience or anything you'd like to sort of add to that? How do you manage those two priorities?
It's a bit of a trade-off, isn't it? And I know we've had these conversations. So just give you an example. I talked earlier about the reusable tourniquets. Now, national IP guidance says that they should be single use. So actually, we took this back to our National Procurement Agency, because they didn't actually. There was no line listing for reusable tourniquets at that time, and we were having this meeting as in national groups saying, this is absolute madness. We can put process and procedure in around reusable tourniquets in some situations that will make it safe for the patient, and we did some work around that. We spoke to the supplier and with our IPC teams, and we said, we talked to them about how we could recycle their products and so on, and we put them in touch with our national procurement provider with supply chain and said, can we start these conversations, and can we also start these conversations at a national level with the infection prevention groups? And we came to a conclusion that actually, so long as we had standard operating procedures in place and guidance around cleaning of these products, that they could be used in organisations under the governance of the infection prevention teams locally, and that has begun to work really well. So, and gloves as well. I mean, you'll all be aware we've just had the Glove Awareness Week for the Royal College of Nursing, and I know Rose Gallagher's worked very, very, very hard there to try and develop this massive open online learning platform for people to understand appropriate use of gloves, so that we can sort of pull back on because we're all using gloves inappropriately now, aren't we? Post, I think we were pre-pandemic, but much more so now. So we're hoping to save, and we've put things in place like we're looking at how we actually handle gloves. So actually having some units fixed to a wall where we can actually dispense gloves by the cuff, so that we can dispense one at a time, and actually that will show some infection prevention improvements, because at the moment we put our hand into a box of gloves, we pull 6 out, we throw some of them away, some of them go on the floor. We've contaminated all the gloves in the box anyway, because we've put our hands in there. So actually, if we can pull one at a time, then we'll cut down on waste, and actually we'll improve cross-contamination, potential cross-contamination as well. So all these, all these discussions are going on around us. Another one I can think about is reusable face masks. So we're almost there with some, surgical reusable face masks that NHS staff can use in designated areas, that can be washed. And of course, the IPC teams have had a lot of engagement around that as well. Reusable theatre hats as well. Theatre hats aren't classed as PPE, so done some work around that, and that from a communications point of view as well. So having different coloured theatre hats so that you can identify different staff groups in theatre, and you can identify the likes of me going into theatre as a visitor or as a relative sometimes, because sometimes we do have relatives in theatre. So so we've identified some significant savings there, but of course we've done this in alignment with the infection prevention teams as well, who've had to agree to them being part of uniform and not having to be a sterile piece of kit and so on. So they're integral to all of our conversations.
Yeah, I think
Paddy,
Matthew, you've covered all of the questions.
I just wanted to ask Matthew something, if that's okay, Paddy. There has been a question that's come up from an infection control point of view, and thank you for covering that, Sian. What is happening is the two coming together, the two departments. So from your experience, Matthew, are the net zero champions actually working together with the infection prevention and control teams? Because of course sustainability is your area, or the key area there, and they will need some guidance bringing the two fields together. Thank you.
So interestingly, we're in the middle of a piece of the project on exactly this issue. So as I mentioned in when I did my talk, we helped the IPC teams encourage the far more extensive use of PPE during the pandemic. We're now helping them in a piece of work that's developing and will come out to the front line shortly on trying to encourage people to go back to the pre-pandemic behaviours and actually go further than that, because there was waste in that, as I thought Sian would be able to wax lyrical on. So yes, and one of the things in those conversations that we've been looking at, helping them with animations and posters and encouraging team leaders to encourage IPC leads to encourage teams and so on, to reduce glove use and open use and all that. And one of the things we've been talking to them about is that tick all the boxes thing I was describing, and that there's a greener NHS motivator in reducing this. It's much easier to not have to keep changing your gloves motivator. There's hand washing is actually in most circumstances better in terms of IPC than gloves, and all of these types of things. But so the answer is yes. We're building it at the moment. It's not coming out yet. So trying to align IPC best practice with the greener NHS agenda.
Thank you, Matthew. Paddy, did you see that there is a question from Hira Singh? What about dressings used in primary care and prescribed or issued by GP practices? I know that you did touch on prescriptions. Would you like to answer that, please?
In relation to a higher volume, I guess one of the things that we've seen in the research we've done around ONPOS and non-prescription is the delays in sourcing through FP10. So the ONPOS and non-prescription systems allow for a much quicker delivery and availability of product. And you're allowed to, it's like a stock replenishing service. But we've seen delays, and which have been exacerbated by COVID, of up to 7 to 10 days in some cases.
Thank
in
you.
source of that. So that lends itself to further complications and impacts on the treatment plan that's put in place for those patients. I hope that answers the question.
It does, thank you. Yeah, there's just a couple of others. Well, there's quite a few. People are asking if the NW CSP are indeed including guidance, you know, on their website on how the health systems can implement evidence wound-related sustainability projects. I'm going to put a poll up now. We have obviously run over, so the poll will be going out to the rest of the registrants as well. I'm going to just be popping another poll up now to ask indeed
Jen,
whether or not you are involved.
There are two consultations for those interested in getting involved in the National Wound Care Strategy Programme, and they can go onto the website and register an interest, because there are two consultations out at the moment, one around clinical evidence, which is, I know it doesn't specifically mention sustainability, and the other is around supply routes. So they're actively encouraging clinicians and suppliers to complete those. So if you're not already aware of those consultations, I'd encourage you to go on to the National Wound Care Strategy Programme website, and you can get access to those documents and then access to the surveys for completion. Timelines are tight though. It's the request completion by the end of this month.
Okay, so
thanks, Paddy. We've got the poll up now, so we're at 60%, 66% are saying that they have answered yes, that there is something in process, and it is indeed related to wound care. And 33% are actually saying that they know the project title. So maybe we could pop those titles in the chat bar. I'm very aware of the time. The chat log will be being produced into a questionnaire and sent to all three speakers. So if there is indeed anything that we haven't covered in today's session, we can address that, and it will be sent out to all registrants. So I'll leave you to wrap up if you'd like, Matthew.
Yeah, and sorry everyone for having to pass the baton on the chairing. Thank you, Paddy, for covering that. And thank you, Sian, for handling most of the questions as well. And thank you everyone for joining us, and also those of you still on who stuck with us after time. Hope it was interesting and useful, and that you can take something back to your roles from this, and look forward to seeing you all at the next wound care event. Yeah, okay, so from all of us, goodbye.